Hello, everyone. Thank you for attending today's webinar, Addressing Common Barriers to Patient Discharge with Innovative Home-Based Care Solutions, presented by Bioformus. My name is Joan Wiseman, and I'll be hosting this webinar. Just a few notes before I hand it off to our remarkable panel of speakers. You can actually read the full speaker bios on the left side of your window by selecting the Speakers tab. There are additional resources available with today's presentation, and you can download those by clicking the Handouts tab on the left side of your screen. There are also closed captions available, and if you'd like those, you can access them from the bottom right corner of the video player. This webinar is being recorded and will be available to watch on demand within 24 hours. We would love to hear from you. During the presentation, please submit any questions you have using the Q&A tab on the left side of your screen. Time permitting, the panel will conclude with a Q&A session and cover as many as they can. And now I'd like to introduce Sarah Bell, who is the VP of Product and Clinical Implementation at Bioformus, who will be moderating this webinar and introducing the other speakers. Sarah, please go ahead.
Great. Thanks, Joan. Welcome everybody to this wonderful webinar. We have a fantastic set of panelists today, and I will let them introduce themselves in just a moment. Lauren Hopkins is the AVP of Virtual Care and Community Engagement with Wellstar MCG Health. We have John Barisma. He's the Manager of Care Coordination and Pop Health at Beacon Health System. And then we have Carrie Peterson, who's the Manager of Clinical Operations at Wellspan at Home. Let's get it kicked off, and I want to start with Lauren. If you wouldn't mind giving us a little intro and kind of talk about the program that you have running today.
Yeah. Hey, everybody. Nice to be with you guys today. I am Lauren Hopkins. I work here in Augusta, Georgia. And so I'm affiliated with the Medical College of Georgia, which is currently the 8th largest medical school in the country. We're really proud of that. And so we have been working in rolling out our Care at Home or virtual Care at Home programs since 2021. And I am currently over all of our population health and transitional care programs. So what we really tried to do was embed this type of care at home as a transitional care approach to supporting our patients in meeting them where they're at, right? And helping those that are truly higher risk. Frequent flyers are our friendly faces that we have here in Augusta. We started the program during COVID, just like most other health systems. However, what we did is we took a more innovative approach and started evolving our program to be a foundational early discharge as well as targeting readmissions. We did get the CMS approval for hospital at home. However, we've been still actively working with the state of Georgia to launch that program. So right now what we have is we call a post-admit at home program that allows our patients to have early discharge into the home. And then we provide some of the foundational elements that you have in hospital at home, in home care through paramedics or an RN, virtual 24/7 monitoring, and have successfully treated over 1,500 patients with 12,000 patient days since 2021. So we're really proud of what we've done and have continued to evolve our program to meet the needs of our population, as well as the needs of our clinical providers to address their populations. Most interestingly, one we really started that we're proud of in September of this past year is postpartum hypertension or preeclampsia. And that's been a huge game changer for us here at the health system. Georgia is one of the lowest states for outcomes and maternal mortality. And so we've really tried to target how we can address those issues through our virtual care at home programs.
Awesome. Thank you. So good to have you. John, could you introduce yourself?
Yeah, certainly. Hello, everyone. My name is John Brunsma. I am the manager for care coordination and population health at Beacon Health System. So Beacon Health System is a 7-hospital health system here in northwestern Indiana. And we recently added a critical access hospital in Three Rivers, Michigan. So we do kind of straddle that border between Indiana and Michigan. We introduced Bioformus as a post-acute hospital follow-up monitoring period for 30 days for our CHF and COPD population last year in March. So we just have 1 year of experience with remote monitoring. But our goal really in rolling that out was to determine, how this program can work for our chronically ill patients and to explore other use cases in the system. And I'm excited to be working with the Bioformis team on a couple new care pathways that we can use to better support our patient population as well. We also, much like Lauren Hopkins, we also received the CMS Hospital at Home waiver, but we have yet to deploy a full hospital at home program. And truth be told, we're probably in the early stages of the progression that Lauren just described, where we are still sort of feeling out how we can protocolize some early discharge pathways for specific sets of patients here at Beacon, as well as then exploring other ways that we can serve our patient population, which really include a wide variety of individuals, both from urban areas as well as a fairly rural outlying area that we serve. So remote monitoring is definitely part of that picture, as well as some other programs like the early discharge or even community paramedicine are things that are on the table here at Beacon for evolving strategies.
Great, thanks, John. And then last but certainly not least is Carrie from Wellspan.
Hi, I'm Carrie Peterson. I'm the manager and the clinical operations manager of Wellspan at Home's program. Wellspan is in central Pennsylvania, and we have a 5-hospital system approaching 4. We're in the process of acquiring a 6th hospital setting. So a little bit about Hospital at Home. We've been doing remote patient monitoring in Hospital at Home since 2019. We most recently transitioned our remote patient monitoring platform to Bioformis, which we love. We have looked at different pathways as we're building our remote patient monitoring and expanding it. We currently, as I said, we do have the CMS approval for Hospital at Home, so we have the ambulatory and inpatient arms that we've been working and expanding on since 2019.
To really kind of talk about our topic today, which is focusing on how we address barriers to patient discharge and what are out there in terms of innovative home care solutions. So just to kind of reset us a little bit with some statistics, we know that hospital capacity has increased by 19% over the last 3 years. And we also know that labor costs are going up. And our readmission rates have risen since 2015. I think the combination of labor shortages, of the rising costs of care are putting us in this pinch point. Our hospitals are full, and really want to look at how has inpatient capacity strain, the resource constraints and increased hospital length of stay, how is that impacting your organization today? And John, if we could start with you.
Sure. Yeah. I mean, these challenges are probably not news to anyone on the call, but certainly during the 2021-2022 period, we were stretched in terms of capacity. We still have multiple days per week where we are boarding patients in our emergency departments here at our 2 main hospitals, Memorial and Elkhart General, in northern Indiana. And I will say, that has had significant financial impact on our organization, as well as then just, the pressure that puts on inpatient staff, whether we're talking about providers, nurses, or other members of the multidisciplinary inpatient staff team. We have observed very long lengths of stay in the organization. Particularly, during COVID, we saw a lot of post-acute availability that was really limited. We were challenged to get placements at skilled nursing facilities, and that challenge, that bottleneck, really hasn't 100% resolved back to the normal status prior to. And we do have a lot of patients that I think are hospitalized while we are awaiting more information, right? There are certain segments of the inpatient population that maybe we're waiting on a test or a result or a treatment to come back on, who have the potential to return home while they're awaiting that information. But our providers really are concerned about the ability to discharge patients if they don't have all of the information. Over the course of the last 3-4 years, I think our inpatient population has become more and more acute, right? And those patients do require some more intensive treatments. I don't have any firm numbers or data to share around it, but anecdotally, right, the chronic illness exacerbations that we've seen in the hospital look much more advanced than they did in large part, I think, prior to our experience through the pandemic. So the patients that are coming in sicker and requiring more and more complex care before we feel safe discharging back to a residential setting.
Yeah, absolutely. And Carrie, I just want to kind of bring you in on this conversation. Wellspan is a pretty robust post-acute program, and your hospital at home program. How are you leveraging these types of programs to help offload your capacity strain and some of your resource constraints at your organization? Let's kick that one over to Lauren. Sorry, I can't hear you, Carrie.
Sorry, I muted myself again and forgot to unmute myself. I apologize. We have we're having a lot of bed crunch, just like everybody else in the system. So we look at every patient. I have nurses and providers looking at patients within the hospital that might meet criteria for the hospital at home program. We identify those patients and go with the assistance of the providers in the hospital, decide whether the patient would do good at home. So we are bringing a lot of those acute patients home, caring for them, trying to identify more and more populations that would do well at home, that we could oversee them by our hospital at home program.
Can we talk a little bit, and Lauren, I might bring you in on this. How do you identify patients who can be cared for in the home? Like, what's that process look like?
That's a great question. I think we get a lot of patients that they're like, hey, can you do neuro checks, right? We get a lot of neuro check requests. I'm like, yeah, I'm not at the point where I'm setting up a camera on their TV, right, and doing sensors. We're maybe one day. But I think it's really important, and the way we have really looked at this is that we're a discharge disposition that our physicians and care team members should look at as an option to put patients in, just like they would for swing bed or home health. How can we help those patients? And so what we've developed is a peer-to-peer handoff, where we get the referral in and it outlines the care plan. And then we have peer-to-peer reviews, so we can ensure on our side we can execute the care plan. Our strategy from patient selection has evolved from condition-based to how do we fill gaps for the patients once they go home. Going to, what was stated earlier, our physicians don't want to let patients go home earlier if they feel like they can't get their meds or won't be able to pick up their DME, right, if those orders haven't processed. So our team really helps to fill the gap. We say we are the bridge between the inpatient to when they get back to their primary care, their specialist team. We help to ensure those gaps are being closed. So we really have looked at it as just an evolution of a traditional transitional care model, just with enhancements to really fit the needs of those patients that are a little bit more high risk and need some more frequent touch points.
Yeah, absolutely. And I like that. It's a bridge. It's not a replacement. It's a way to get patients out of the hospital a little bit sooner. And John, being a newer program, I think, could you speak to a little bit? It's hard to change culture. It's hard to tell hospital physicians, hey, you can send this patient home. We have them. Can you talk a little bit about just the struggles that Beacon's going through in trying to convince or have that conversation, that change management to allow patients to go home on a program?
Yeah, for sure. I guess, there's this tension that you walk, especially, I reference back to while we were rolling out some of our length of stay initiatives aimed at reducing length of stay. I heard just, kind of hallway conversations amongst providers kind of saying like, well, first you were saying that we need to pay attention to 30-day readmissions. You don't want these patients coming back to the hospital. Now you're telling us to discharge them sooner. I feel like those two things are in opposition. And so I think, there is this kind of culture that has developed where when you have the patient there in the hospital, they're at captive audience, and you're going to, make a mad dash while the patient is there to do everything you need to do to that patient to make sure that they don't readmit, to get them well and, prevent them from coming back. But, because after they leave, I think your inpatient providers in large part feel like, well, the patient is outside of our control now, right? We can't, we don't want to be a part of what extending treatment happens after they leave our doors. And I think that's the culture that we're still, kind of trying to come up against, that kind of outdated mold, that outdated model, and break that, socialize a new way of thinking about that discharge disposition to home with remote monitoring, or the earlier, the timely discharge with remote monitoring. So that is, what we're working with here at Beacon right now is, can I trust that these new tools that are being offered for my patient are actually going to work? Do I feel confident enough that handoff to this next care team, right? The bioinformatics care team, or the ambulatory care team, the care coordination staff, who are essentially monitoring and following this patient, that they're going to do the things that are necessary in order to resolve the things that I would normally be able to see in my bricks and mortar, physical facility here. Now, encouragingly, right, I've had emergency department doctors say, I've had inpatient hospitalists say, if I knew that this patient would have, monitoring as soon as they leave, if I knew that they would be followed with their primary care doctor within 48 hours of discharge, if I knew that, say, for instance, they're going to get a home visit from a community paramedic with the community paramedicine program, I would feel comfortable either not admitting them from the emergency department or sending them home while we're still awaiting those, UTI culture results to come back, while we're still waiting for, those labs to come back through and to fully titrate, whatever medication we're hoping to send them home on. So I think we're starting to see where providers can see this starting to fit into the patient care pathway, but we still have some ground to gain.
Yeah, absolutely. And Carrie, you have a robust program at Wellspan. Can you talk a little bit about how you've overcome some of those barriers? John's in the early part of the journey, trying to ramp, you're a sales guy. You're getting out there, you're meeting people, you're trying to say, hey, trust us with your patient, we can do this. Can you talk a little bit about your journey at Wellspan and kind of getting to the point where I think you could say patients are starting to flow to you and it's less of an active pull, although that never goes away.
Yeah, it's always a pull, but you hit the nail on the head when you said culture change. It is a culture change and trust. It took us a long time, and I can't even say we've overcome that battle yet, but we have our hospital at home program. We do as much in the house as we possibly can. We could do chest x-rays. We have a team of nurses that go in every day to the patients, depending on their diagnosis, once or twice a day. They do a provider video visit every single day. So those patients are being looked at every day that they're on our service. after post-discharge from hospital at home, our nurses continue to keep up with them. We check in once a week, the first week a couple more times, but once a week. We do check on them for at least to get to our 30-day mark. Our readmission rates for our hospital at home program since 2019 is 5%. So we have a very low readmission rate, which we're very proud of and work very hard for. We do use remote patient monitoring. They do stay on the remote patient monitoring post-discharge from hospital at home. Very important, because that group of nurses are looking at that patient every day to say, all right, their vital signs are creeping up here. This could be going on. They could be exacerbating. Then we get our providers from our hospital at home team will reach out to the patient, see what's going on. So we keep in constant contact. Same providers that oversee remote patient monitor oversee hospital at home. We also have an advanced illness management program run by the same group of nurse practitioners. Those are for those acute patients that are just high utilizers in the system, constantly readmission. We have those providers on service with those patients, and it's that bridge to their PCP. So if they are starting to exacerbate, they call us. We look at them, reach out to the PCP, kind of come up with a plan, and whether it's get them on the hospital at home service or get them into the PCP quickly. That's one of the strategies we've had over the last couple of years. We've been doing that as well. We also starting our provider at home program. We're going to pilot that hopefully probably midsummer this year. That's just going to be another added resource for these patients. But definitely that remote patient monitoring, I think, is the strongest, our strongest asset with our program, because they'll watch those patients we keep them on for 60 to 90 days afterwards.
Lauren, anything you want to add?
Yeah, I love to hear that, because we have a very similar approach with us we're a level 1 trauma center serviced in a 13-county region in Georgia and South Carolina. Very similar to Beacon. We have urban, right? I'm in Augusta, but I'm in a rural area. And a lot of these patients are being transferred to us from outside facilities. And so we actually have a pretty robust service line for virtual care services that does include the hospital at home, our observation at home programs, the post-admit, and our discharge programs. But we also have a virtual tele-ER critical care program as well. And so what we've really created too is helping with throughput, not just in our own backyard, right? When a patient comes in, trying to identify early discharge patients, creating that collaboration. And we have successfully been able to do that. But what we really have been growing is our outreach into those rural communities. And I think that's really important, is that for us in Augusta, is if we can try to what Mary was just saying, keep them out for 30 days. It's not just that single 5 to 7 days, right? If you do not work hard to keep them out for 30 full days, they're going to be right back in the hospital. So having strong relationships with your primary care, having strong handoffs with your non-owned hospital partners, right? Clinics in your community are important. And that's what we've really tried to do with our rural health partners, is develop a handoff. So if a patient comes transferred in and they actually are going back maybe to Swainsboro, Georgia, which is about 45 minutes to 50 minutes away, we have a handoff to their primary care provider, right? To let them know that that patient is in our program. Here's what to expect. And we collaborate on a care plan. So if they go to their PCP office, maybe their PCP wants to modify some of the medications, then we on our side ensure those meds are actually being taken correctly, right? Because we know what happens in the home. It's the wild, wild west sometimes out there, guys. And you just never know what to expect. So you've got to go in and you've got to work on not just engagement with the patient, but it's becoming patient activation. That's what I really like about remote monitoring, is it's really pushing to get activation with patients, which is where you start to see them change behaviors and habits when they have to take accountability for their own vital sign monitoring and recognizing, oh, that's too high. That nurse is going to call me. I don't want her calling me anymore than she has to, right? So I'm going to do what I'm supposed to do. And that's what we've really recognized in being able to use. And I agree, remote monitoring is a powerful tool. You got to have the right population. It's not for every patient, which is why patient selection becomes so important. And it also, too, has to be multidisciplinary. It's not just the physician. It's not just the nurse. It's the whole care team that's got to be involved to really make active changes for the patient and their behavior.
Yeah, absolutely. And kind of the theme here is it takes a village to keep patients out of the hospital or care for them. We have different care teams, we have different programs, we have different, people to help keep them out of the hospital and help them on their healthcare journey. And with all of that, we have a really good question that came in is all of that is data. We have notes, we have vital sign data, you have continuous data, you have episodic data, you have, data for days coming in. How is there a risk of having too much data? Personally, being in healthcare, I love every data point possible. But is there a risk of too much data? And if not, how do you handle that data? What does that look like coming in? And I might kick it back to you, Lauren.
Yeah, I was going to say, I'll jump in. So I think as you're moving into a virtual model, it's not the same as in-person care. We all know that. You have to learn how to be trained and educated to take care of patients in a virtual world. So our partnership with the Medical College of Georgia has really enabled us to do that, where we're really training and teaching our future learners, but also our current providers on how to deliver care virtually, right? Same with the nurses, same with, respiratory therapists, whoever it is. What I would say from the data standpoint is that you have to learn that in the hospital, you may respond one way when a patient's alert goes off or their vital signs hits a certain parameter. At home, you've got to become more comfortable with that threshold may look a little different, right? And your actions may be a little different on how you respond to escalations. And I think that just takes comfortability of learning how to look at data, putting in what really is going on with the patient. You have to get individualized with that patient parameters in order to really make sure there's no erroneous escalations. And you're reporting as well to the signs, the symptoms back to that provider, right? So you've got to have a very, very detailed and virtual assessment that has to be done. So the provider gets the whole picture, right? It's not like they can just walk down the hall and see the patient. They're very, very reliant on the nurse or the paramedic, whoever's in the home or on the virtual visit, to tell them what is really going on with the patient. So I personally don't think there's too much data. We have a care team 24/7 that's looking at the data. It's how you analyze it. It's how you use the data, right? And you have to have very specific protocols in place, protocols that your care teams all feel comfortable with and understand how to utilize in the correct manner. And then have a very, very robust and safe, escalation plan in place, right? How are you going to escalate? When do you escalate versus when do we just recheck the vitals versus when do I need to send somebody in the home, right? You have to also, too, part of this is we're working with devices that may not be the same medical grade that you have in the hospital. So you have to learn, too, you may need to repeat it because it may have just been patient error. And so instead of getting all yourself worked up and getting the patient all worked up, like, hey, calm down, let's recheck that, right? Or the vital patch we use from Bioformis, we have a fall triage protocol, right? Because patients will sit down too hard in their chair and you think they're a fall, but you got to learn to assess those things correctly instead of just pulling the trigger thinking everything is, doom and gloom type of scenarios.
Yeah, absolutely. Carrie, what about you all at Wellspan? How do you handle all of the data points, whether it's continuous or episodic, and what does that look like?
Great questions, and I agree with Lauren as well. Analyzing and utilizing all of our data is important. Our patients are looked at by any alert that comes in. Every single patient is looked at. We reach out to them, do that reassessment if they gain 10 pounds in a day, how did they gain 10 pounds in a day? What did you eat? Are you dressed? Are you doing it first thing in the morning, weighing yourself first thing in the morning? So it is doing that individual assessment and then taking the next step, depending on the information you receive. Never too much data. I'm a strong believer in having a lot of data.
Yeah, absolutely.
So,
Go ahead,
Sarah,
John.
if I could, an observation in that question, there's one word that stands out to me, and it's the word. I guess the question is phrased: how do providers handle all the extra data points? And I would just point out, right, that in most of the workflows that we're describing here, the incoming data isn't all necessarily being managed by a provider. And I will share candidly, as we were rolling out our remote patient monitoring program, there was a significant concern among our primary care providers that, having those vital signs flowing through, even for episodically collected data where you have 2 vital signs per day, a normal primary care doctor is not used to seeing 2 weight values per day, 2 blood pressures per day in a lab value result, flow chart. They wouldn't necessarily know what to do with that information, but that information is being managed by a clinical care team with protocolized nurse-driven pathways, and then communicated to the provider when there is something of concern that requires the provider's response. And we really had to spend a lot of time at Beacon figuring out exactly what that communication would entail, right? So when is the nurse reaching out to the provider? What specifically are they communicating, and how are they communicating that? What's the expectation for a response time from the provider? All of those different expectations are things that we had to take consideration of and really create a process for at Beacon before our primary care providers felt confident that they would be able to handle the additional data coming through. But yeah, on the surface, I think a provider would feel a lot of concern if they are getting that much data back. At that point, it becomes more just noise as opposed to helpful information. That's where the driven protocol come in.
Fantastic point. And protocolizing is key here. How can we empower our nurses or our health navigators, our care team members to, do that next level assessment before we escalate to a provider? Because you're correct. We're not getting more providers either. So we have to manage patients in an efficient manner. I wanted to talk a little bit about this sweet spot. We know post-acute RPM has been around. We can all be honest, nobody's making loads of money off implementing a post-acute RPM model. You're not reimbursing, the reimbursement back on that is not huge. Hospital at home is hard. It's resource intensive. And Lauren, I wanted you to talk about, you kind of threaded that in-between space where they're not full hospital at home, but they're getting a little extra than your post-acute RPM patient in the home. Could you talk about that?
Yeah, for sure. So 100% agree. RPM on the surface it's not a moneymaker, right? It's the downstream impacts you're trying to achieve with it. For us, when we started our program up initially, was to get patients out earlier from the hospital to assist us with throughput. And what we learned very early on during our COVID journey with that population is the immediate financial outcomes that this program had for us as a health system. So on average, every patient that is being discharged from the hospital, brick and mortar, into our post-admitted home program is cutting their length of stay by 1.56 days. And so what we've been able to do is, by having a foundational program that is very similar to hospital at home, we do in-person visits within the first 24 hours of discharge. They get a virtual physician visit within that first 24 hours. They still potentially have continuous monitoring depending on their condition and risk. They have episodic monitoring. We do that intensely for about 5 to 7 days. The average length of stay is around a little longer right now. It's at 6 days. We do have some sicker patients we've been having to take care of. But once that patient hits that time frame, then we actually scale it back to close out just their 30-day cycle, right, from the hospital. And so we are very protocolized even for that 30-day cycle. We have condition-specific guidelines that explain how often, we're going into the home. What does that look like, the frequency? And we take into consideration their LACE score, which that's a readmission predictor. We look at chronic conditions, their history of readmissions, and we may provide more in-home services than a patient who is lower risk, right? But what we've been able to do by getting those patients out early, as well as we admit directly from the emergency department and our clinics into this program. So any patient who may have an acute problem that could be managed in home, like an acute sensitive or ambulatory sensitive condition, could be enrolled in this program, right? Which would avoid an unnecessary admission or avoid an ER visit altogether. And so we've been able to reduce our inpatient bed days. We're helping to save about 6.8 per day currently. So going back, heard Beacon, you talking about y'all have ER holds. We do too, right? We have about 20 to 30 per day. Well, without our program, that would be closer to 40 to 50. And so we have an average daily census today of around 52 patients in our program. And so we are deploying those resources. To Sarah's point, it's been a journey. We've had to learn how to become more efficient because it's not a 6-to-1 nursing ratio model, right? You're not on the floor. You got to learn to better utilize your tools, which comes into how do you train people? How do you orient them to this model of care so you can take on and add more patients to your census, which helps your return on investment in your pro forma to take a look and say, oh, I can take care of 50 patients. Then if I'm cutting 50 patients length of stay by 1.56 days, that profit margin starts rising up. And my CFO is keep it going, right? So that's what you got to really look at. The other thing too is, of course, readmissions. In this program, our system-wide readmission rate was closer to 15-17% because of just some of the complex patients. We do have a children's hospital as well. So, of course, we have a NICU. We've got a PICU. So we've got some higher readmission rates on both sides. But this program, we've been able to actually drop that readmission rate down to 7% is our overall readmission rate for this holistic program, which is really phenomenal for the patient population we've been able to take care of.
Yeah, that's amazing. And there was a question that came in about PEDS and NICU. Have you looked at the value prop of expanding to that patient population as well?
Yes. And we are actively exploring it. I think I probably, bug Sarah and Ian all the time. Like, when can I get PEDS equipment? When can I do PEDS? Right. Because we do see the value, especially in that younger population, asthma, childhood diabetes, going ahead and beginning to create that care pathway for those patients. Going back to patient activation, we have nurse navigators and patient navigators in our ambulatory care clinics. And so that would become a partnership with them to help manage that acute issue, hopefully try to help change that behavior for not just the patient, but their family, right? And that's really key too, is that this program is very much, don't look at it as you're just doing remote monitoring. In order to really be successful with this program, it has to be a comprehensive, holistic view to taking care of the patient. We have social workers, we have chaplain support, we have those resources because that's what's going to take when the patient goes home. You've got to figure out what's driving them and connect to them in order to really get that behavior to start changing. And that goes when you're taking care of pediatric population, it's the parents, right? The child can't control if they can get to the doctor or not. So you got to connect with the parents. We also too, with the postpartum population, I would say as well, that's been an interesting one to work with because we do have a lot of younger mothers. And so we're not just working with the mother, we're also now working with the mother's mother, right? And so it becomes a very interesting dynamic while they're trying to learn how to navigate, motherhood. We're also trying to teach them, okay, I need you to take your blood pressure and let me explain to you why. And so, part of this is a lot of patient education, a lot of motivational interviewing. We are constantly looking at skills like that to enhance our nurses' ability so we have better success in keeping patients out and reducing that length of stay, because our providers trust to know that when the patient gets our program, the outcomes they're going to get are high with great quality of care. And that's what we really strive to do in our program.
Yeah, absolutely. And I wanted to ask a little bit, we're getting a couple questions in about patient selection. And as you talk about, bioinformatics, we call it timely discharge, but anytime we're getting a patient out before they would have normally come out, so whether they're going to post-acute RPM or they're getting a few in-home services, and then you have post-acute RPM, you might have maternal fetal medicine programs. What does it look like? And John, I'm going to start with you at Beacon. What are the suite of tools needed to find these patients in the hospital? How do you surface those patients to your team that's going to go, give that sales pitch, that's going to go get the patient enrolled and get them home?
Yeah, certainly. So our existing structure included, some positions that really are integrated into the inpatient process. Care coordinators who spend face-to-face time with patients at the bedside, educating them potentially on a new diagnosis, interviewing them on what their living situation is like, making sure that they understand, the self-management strategies for living with chronic illnesses. And so those are the positions that really vet the patient and look at the inclusion-exclusion criteria and try to identify those patients that are most likely to benefit from remote patient monitoring. So some of the things that they really look at are the patient's likelihood to readmit and the patient's understanding of how to manage symptoms, how to manage medications, those types of things. Some of the barriers that sometimes come up especially for the chronic illness patient population, are patients who potentially have slightly limited cognition, or patients who, are not as familiar with some of the tech that's involved. And so in those types of situations, we really do kind of go a level deeper and talk with the patient about family and living supports, and begin to pull in those caregivers. And instead of educating the patient on the use of the platform, we focus then on the caregiver who's present. And a lot of times by working with the family caregiver who's, kind of at the elbow for that older adult, you can actually facilitate a really good experience.
Carrie, Wellspan has a robust program, as I've mentioned. What does patient selection look like there? What are the tools? Do you use case management? Do you have a dedicated team? Tell us a little bit about the makeup of the team or the tools used to find those patients who can fit.
So that's an interesting question. We are trying to find ways to work around case management because we don't have a lot of case management support at Wellspan. They pick and choose which patients they want or don't want to go on service. So it's more of us pulling. It's always a pulling with home health. So we look at patients that we identify them based on what our pathways are, reaching out to different programs. So I know we've talked about maternal fetal medicine. That's going to be new waters for us. We are meeting with them and coming up with different pathways we want to potentially develop for this group of this population. We have a lot of rural areas that we don't get the patient buy-in either. So our goal is to find ways to communicate with the patient prior to discharge, the importance of RPM and what it could do for them, how it can help them learn about their disease process and how they could manage it better to have a more productive lifestyle, what they're willing to do, really. So we have a central intake team that does reach out to each referral, kind of go through, what our expectations are for the program and how it can help them. Then our remote patient monitoring team jumps on next, and we help them with medication understanding, why you take that medication, what will do if you don't take the medication, why aren't you taking your medication. We want to dig deep into what their social barriers might be. So it's definitely a great support to keep the patients, teach the patients, because we don't just use remote patient monitoring to just monitor vital signs. We make sure they have a understanding. So we do more education in our pathways also, so they make sure they have an understanding of what they have to do once we're not there. So that's a little bit about how we use remote patient monitoring to help out our
Yeah,
programs.
absolutely. Lauren, any deep dive into how you all find patients? What does that look like?
Yeah, so today with our current program, it's more, like Carrie just said, it's a pool, right? We're going and looking for those patients. And once we identify them, then we engage case management, we engage that social worker, whoever's on that care team to ensure we have a sound discharge plan together, right? What is the goal? What are we trying to achieve? In our future state model, what we have envisioned is that we have an admitting physician that is actually a part of our hospitalist team that while they're doing the admissions and identifying patients in the hospital, in the ER, right, to also so that way we kind of have more of an active engagement. It is a pool, but we have a physician who's going in there and looking at what the medical needs would be, and then helping to determine what's best suited for the patient, right? What program is great. The way we've set ours up is all the way from hospital at home to, a lower intensity enhanced only monitoring program at home. And then that way, that physician who we also see them doing tele shifts, right? Working in this program, treating patients. So they know what to expect. They know what our capabilities are. So then they're in the hospital, they can relay that to their counterparts, their colleagues, and be like, hey, this would be a great patient for us to place in observation at home. Let's go ahead and put them on the CDU unit for about 4 to 8 hours. Let's do X, Y, and Z diagnostics. Let's go ahead and get this testing done. And then we're going to transition them into the observation at home program and see how they do. So that's really what we envision in the future state, as well as continuing to have that pool active engagement with our care teams, looking at census, looking at number of readmissions, their LACE score, so we can help not only patients get into hospital at home, but those that are already in the brick and mortar facility who need a better transition plan. Maybe they were denied for SNF, right? Maybe they were denied for a swing bed. This is a patient who who could use us, right? We say this is needing a patient who needs a little bit more tender love and care when they go into the home-based setting, and that's where we're here to provide that support for them.
Yeah, absolutely.
Yeah.
It takes many people. Go ahead, John, if you want to add to that.
Well, just as Lauren was talking, I am reminded of some of the parts of our journey where we've had to really kind of come up with creative solutions for some of our patients. And we talked about the importance of protocolizing everything on the selection and inclusion, exclusion criteria for remote monitoring. I would almost say this is the one area where you don't want to have extremely static protocols, right? Because you may start to rule out certain patients who could really benefit from the program. Mm-hmm. If your team can think creatively about how to solve certain problems. So, for instance, the patient who doesn't have good cell reception at their house, can we bring out a MiFi hotspot and allow the patient to participate in remote monitoring by using that in a rural area? We've done that for some of our patients. If there is a patient, with limited cognition, who can we train, or could we even deploy, an attendant care agency to that patient's location to help them collect their vitals? So how can we think creatively about those types of patients? And the other thing that Lauren said that really stood out to me earlier in the conversation is developing those relationships with non-employed physician groups. And Sarah, you're familiar with our journey at Beacon. For probably the first half of the year that we rolled this out, we were really stymied and couldn't get the patient volumes that we wanted on remote monitoring because we had limited our patient population to only those with a Beacon Health System employed primary care doctor. We were concerned that we wouldn't have the buy-in from other providers in the community if their patients were leaving our hospitals on remote monitoring and should need, say, an order for a new medication or would have an escalation that would require a visit. But surprisingly, the conversation was a lot easier to have with those non-employed physician groups. They were grateful for the additional tool and resource and were quite receptive when we reached out. So we've now branched out and we've linked arms with a lot of our FQHCs in town that follow patients after they discharge from our acute facilities. So making sure that you do prioritize building those relationships and those pathways in the community as you're thinking about a program like this will really help with your selection criteria as well, and it'll open up, discharge for patients onto remote monitoring or care at home who really need this, who otherwise, might be excluded just because of a logistical barrier that, that they have no control over as a patient.
Yeah, one of the things I've always thought about too, and this is future thinking, but is there a time when it becomes people have to rule out and rule into the hospital instead of like how do we get to the point where everybody should be on a program to get them out of the hospital sooner, whether it's post-acute RPM, whether it's, a timely discharge or an early discharge program or home hospital. And we actually have to, that's their first pathway. And we actually have to include them into the hospital instead. Any thoughts on that? I know that we are way far away from that, but does anybody have thoughts on that concept?
I'll jump in really quick. My medical directors and physicians have begun to say this is now the standard of care, right? This is what we should be doing. And this is where evolution and everything is evolving into the healthcare delivery space. And we know that, and consumerism is driving a lot of this. But on the flip side too, it is a powerful tool. You just have to learn how to use it in your toolkit. And I think I agree with you. We've even discussed how do you add like a 24/7 triage line where we don't own our own EMS system, right? But we have tons of patients who call in. They want to talk to the on-call physician. Well, instead of that, why don't they call my virtual nurse? Let's do a quick virtual visit, triage the patient via telemedicine. Oh, everything looks okay, but I'm going to send my community paramedic out to check on you, right? They're part of our paramedic license, so they have the ACLS medication. So if they get out there and there's a problem, they can stabilize until 911 can come, right? So you got to think about it in that way. I agree, because as staffing shortages continue to drive this, as physician burnout continues, you have to think innovatively about getting the patients the right care at the right time. So I like that concept, Sarah. I agree. I think that's where we're going to end up having to move to as more value-based models also come into the market and take over how we're being reimbursed, and the margin continues to shrink for our hospitals. We've got to look at ways we lower that overall cost of care and really make sure those complex patients are the ones that are in our hospitals, for a hospital like ours. But on the flip side, we have to protect what our rural hospital partners are doing and ensuring that they're getting the right patients. So maybe instead of them being transferred, if they're on that edge, this is what we've been trying to work on, is enhancing our rural hospitals' capabilities to treat more complex patients, and doing that through telemedicine. So then they get into that program, they need discharge, right? Well, they can discharge into our early discharge program, right? So it's still a win-win for both the larger tertiary system that doesn't have the lower complex patients. It's a win for the rural patient because they stay in their rural community, and then they have the support they need through telemedicine and remote monitoring, still connected into the larger facility and get transported or sent back to us as needed.
Yeah, absolutely. Carrie, any thoughts on that from Wellspan's perspective?
I think it's just we continue to have to grow and look at innovative methods to care for more patients in a creative way. I almost say arts and crafts, right? Like, how do we create opportunities to keep the patients out of the home? How do we ensure that they're not going to be readmitted? What support can we give them so they're not readmitted? How do we catch them earlier from exacerbations? So it's just constantly looking at how we could do better, keeping them at home, and what tools we could use, technology, to recognize that at a quicker pace. I have many ideas. I just have to get them all on.
Right. I know this group's not
you got to get support behind it, right?
Exactly. I mean, it takes innovation. It's really hard to do, and there's no right way to do it. And I know John, at Beacon, I mean, I think there was a patient just in working with you all who felt like the program saved their life. Like, and I know that's what keeps all of us going. Patients love being in the home. They like having their dog with them, their cat, they're seeing their grandkids or their kids, and having that fully integrated experience into the home is a very much so a patient satisfier. John, do you want to expand on that at all?
Well, sure. I mean, we did have a really neat story about, a patient who was experiencing some real anomalies in their blood pressure. They wouldn't have been aware that there was any problem had they not been being monitored by Bioformis. And they were able to, they did turn into a 30-day readmission, but that was definitely one of the circumstances where it was very warranted, right? That patient came to the hospital, received life-saving treatment that she probably wouldn't have gotten had she not been alerted by the Bioformis clinical monitoring staff. So, I mean, that was an amazing, eye-opening experience for us as a hospital, just the power of this type of tool. But I would, point out a couple things about, how we can strive to keep patients at home. The one thing that we really haven't talked about too significantly on this call is how we not just look at patients who are already in an acute exacerbation and either get them home earlier from the hospital or facilitate their post-discharge journey so that they don't come back, but how do we work further upstream to identify those patients who maybe aren't complex today, but if we don't do something to help them control their illness now, would become our complex or our frequent flyer population, 5 years down the road. So our team at Beacon actually is working with Sarah and our Bioformis customer success manager to roll out the general medicine care pathway. The whole idea being that this will be an on-ramp from our ambulatory primary care practices for those rising risk patients who really just can't seem to get a good handle on their hypertension or their obesity management or their breathing problem, that maybe it's asthma or bronchitis, not full-blown COPD yet, but they really need that additional real-time support from a chronic illness trained nurse. This type of care model would deliver that so that you actually start to achieve the goal of managing your population and elevating population health over time to really start to curb costs from a much more long-term and upstream type of a vision. The other, I guess, little tidbit that I would just throw out there is as we're talking about innovative ways of delivering care in the home setting, there is a new federal agency actually that we are recently exploring here at Beacon called ARPA-H, and they're specifically rolling out funding aimed at developing new strategies for care delivery. So Beacon has actually partnered with South Bend's, kind of claim to fame is Notre Dame University. We've partnered with Notre Dame on an application to one of their funding models that would help to redesign rural medical care delivery architecture. So when we talk about delivering care in the home setting as kind of the default setting, and anything in the hospital would have to be the exception rather than the rule, I think there are some real tide changes that are starting to happen in terms of how our funding is structured and the oversight agencies, what they're making available too. So if anyone isn't familiar with it, go out there, check out ARPA-H, look at the paradigm model. There's some really neat initiatives that are being suggested at that level as well.
Awesome. Well, we're running out of time, and this has been a fantastic conversation. I think we could have this for hours. Beacon and Wellspan and Wellstar Augusta are just really paving the way in terms of what we're doing at Care in the Home. And so we've just appreciated your partnership as we move forward. So Linda, I'm going to hand it back over to you.
Thank you. Thank you for attending this fierce healthcare webinar and submitting so many fantastic questions. Special thanks to our speakers for participating and Bioformis for presenting today's webinar. You will have access to a recorded version of this webinar within 24 hours. Just use the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.